Hello. We will see in this topic the ill and feverish child. Fever. Most children with a fever have a self-limiting viral infection which resolves without any long-term consequences. However, it is important to exclude the possibility of underlying serious infection. Bacteremia occurs in 4% of febrile children. A thorough history and examination are required to determine the source. Be concerned when less than half the usual amount of feed has been taken in the last day. There is breathing difficulty, or high-pitched continuous moans or cries. There is a history of being pale, mottled, cyanosed, and hot. Dull expression, apathetic, disinterested in you, drowsy, dehydrated. A significant reduction in the number of wet nappies in the last 24 hours. Blood in stool, or seizures, or tachycardia not explained by pain or fever. The third question is neutropenia possible? Example on chemotherapy. A traffic light way, paying especial attention to red signs, pale, mottled, ashen blue, not staying awake when roused. Beware inappropriately normal vital signs. Always listen to your sixth sense. Discuss with a senior doctor if you are uneasy about a patient. Then observe the limbs. Pain causes pseudoparalysis. Example with legs in a frog position, hips and knees semi-flexed, feet rotated outward. Example in osteomyelitis or septic arthritis. The above signs carry extra weight if immunocompromised. Management of a child with fever is according to the traffic light system but use clinical judgment too. Discussion with seniors is essential. Once a diagnosis is reached, treat accordingly. Green features. Manage at home, but consider social and family circumstances, parental instinct or concerns. Contact with serious illness and recent travel. Parents should be instructed to check on their child during the night, offer regular drinks, seek medical advice if the child stops drinking. To look for signs of dehydration, dry mouth, no tears. Look for a non-blanching rash by rolling a glass over the rash. Seek immediate medical advice if present. If the child is well, but the fever continues for greater than 4 days, parents should be reviewed in the emergency department. General doctors cannot diagnose Kawasaki's disease. Parents should not tepid sponge their child and should keep their child off school or nursery. Red or amber features. These children need admission. Red features. Life-threatening illness, child needs urgent treatment. If there is no apparent source of infection, carry out the following. Blood culture, FBC, CRP, electrolytes, urine test for UTI. Lumbar puncture, if clinical assessment dictates it and no contraindications. CXR, if respiratory symptoms, signs and no other focus. Antibiotics, maximum dose third-generation cephalosporins, not ceftriaxone due to risk of calcium chelation, should be given to children with fever and signs of shock or coma, and or signs of meningococcal disease, or suspected N. meningitidis, Streptococcus pneumoniae, E. coli, Staphylococcus aureus, or Haemophilus influenza type B. If herpes simplex encephalitis is suspected, give IV acyclovir. If bacterial meningitis confirmed, some give IV corticosteroid if greater than 3 months. If you have any questions, let me know in the comments. If you like this video, please share and subscribe.